just like to make my disclosure statement. And I would also like to thank Amanda Vincent for some of the slides. So this is a summary, not quite complete, I realise. I want to talk just briefly about childhood and adolescent cancer survivors, cancers not suitable for MHT, breast cancer, and more about the symptoms of breast cancer survivors in terms of vasomotor symptoms, GSM, and then I'll finish up with a little bit about BRCA gene patients. So a lot more women are now surviving through childhood and adolescent cancers, and approximately 70% are now long-term survivors. And there appears to be, from the Childhood Cancer Survivor Study, which is a multi-centred study looking at young ones who've gone through cancer and following them up, they showed that there was an immediate or fairly immediate failure rate of about 6.3%. So those young ones who were adolescent on therapy, post-menstrual, developed 6% of them developed a premature ovarian failure at that stage. But another study looking at the long-term risk of premature menopause in those women under 40 showed that about 6% of those women under 40 became menopausal. This was limited in the sense that it was just a study of solid tumours and didn't include a series of other tumours. But so we've got approximately 6% who will, when they're going through treatment, will become menopausal, and then a risk of about another 6% before the age of 40. Just wanted to briefly mention the cytotoxic agents, and I've just highlighted some of the ones that are used commonly, showing what the risk is in relation to their toxicity on ovarian function. And obviously, cyclophosphamide is used regularly, very often in autoimmune disorders as well. And so these are the ones that have a higher risk of creating ovarian failure. Now, with these young women who have gone through premature menopause for either reason, either related immediately to treatment or later on, they are treated as anyone would be treated if they went through premature ovarian insufficiency. So they go through the routine screening, and they should be having standard high-dose therapy up until the expected age of menopause. So they are completely as we would treat someone with premature menopause. But what about those cancers that are unsuitable for MHT? There aren't too many. And I put breast cancers up there with a question mark because I've had 2 patients in the last month who have had breast cancer and are remaining on their HRT. I'm yet to find out why from their oncologists and breast surgeons, but both of them have said that they're allowed to stay on it. So I'm finding that quite interesting. One is, I think they're both on combined patches. So that's a question that we need to look into a little bit further about why, and because most patients are immediately stopped and taken off their HRT. And then that, of course, raises the issue of symptoms after that. But there are a couple of other reproductive cancers that we would not use HRT in. Endometrial stromal cell sarcomas and recurrent uterine cancers that are greater than grade 1, or any of those such as leiomyosarcoma, that we would not be using estrogen replacement therapy in these women. Now, what about the ovarian cancers? Well, there's quite a lot of controversy about when to use and what to use. But in epithelial cancers, there's been really no data. There's only this small South African study which showed no evidence of any negative effect of using standard MHT in women with ovarian cancer for menopause symptoms. This small study showed that there was a trend towards increased survival in the group. So that's interesting in terms of serous or mucinous adenocarcinomas. Endometrioid ovarian cancer, which we've thought would be a contraindication to estrogen because it's thought to be estrogen sensitive, there's no evidence that there's an adverse effect. There's not a lot of studies done, but there's no evidence at this point in time. The other tumour that we would be reluctant in the past to use hormone therapy, but in fact I have a couple of patients who are on standard hormone therapy. I spoke with Tom Jobling and he said that he is quite happy for them to be on menopause therapy, but he would keep a very close eye on their serum inhibin levels. So they're really, it really is a very positive story in terms of ovarian cancers. Now, what about breast cancer? So we know that when women go through breast cancer in the premenopausal stage, that they will have more severe symptoms than women who are not having breast cancer, but they'll have even more symptoms than those women who have breast cancer after the menopause and may have to go off their HRT. And these symptoms will be persistent and they will continue on long term. And most will have multiple symptoms, as most women do. And the issue about breast cancer survivors and menopause is that they're having to deal with both issues at the same time. And the symptoms will often be worse and the quality of life will be worse than actually being on, for example, their aromatase inhibitors or tamoxifen. And so about 40% of women on those adjuvant therapies will actually discontinue them because of the severity of their menopause symptoms, which may or may not be made worse by the adjuvant therapy. Now, this is a rather complex slide looking at the effect of adjuvant therapy on various parts of function. This side is tamoxifen and this side is anastrozole, and it's looking at the effects that it has on various different parts of the body. And with tamoxifen, there's an increase in vasomotor symptoms of somewhere up to nearly 50%. In 50% of women, they'll have worse symptoms. It doesn't seem to be as great, but the studies are, it's quite a wide number, a range from the different studies. And obviously there is reduced breast cancer, but interesting increased cataracts. It talks about reduced breast cancer, obviously, and then increased cholesterol levels with the AI inhibitor. We've got reduced cholesterol with tamoxifen, but an increase in venous thromboembolism. If we look at the uterus, there's no increase in the risk of uterine cancer, obviously. With tamoxifen, there is an increase in the risk of uterine cancer, fibroids, polyps, and vaginal discharge, because we know that it's a SERM, it's anti-estrogenic on the breast, but it's estrogenic on the uterus. There's no aspect of pelvic floor function which seems to change with tamoxifen, but with the AI inhibitors, there is, because of the profound reduction in estrogen, there can be effect on pelvic floor function and incontinence. With tamoxifen and bone, there is a reduced risk of fracture, and the opposite with the AI inhibitors. So that's something that with the aromatase inhibitors we have to be very careful about and regular. And with the AIs, musculoskeletal disorders of bone pain, muscle pain, in up to about a third of women. And what about bone loss? Well, we've heard about bone loss, but bone loss with cancer therapies, the greatest bone loss is in ovarian failure secondary to chemotherapy. So we see this is what happens with late menopausal women, early menopausal women, aromatase inhibitors, the other AI plus a GnRH agonist. But here we have ovarian failure secondary to chemotherapy gives the largest bone loss at 1 year of about nearly 8%. So a very important group once again in looking at the overall management. In cardiovascular disease, we can see that the risk of cardiovascular disease is in a particular study with stage 2 or 3 ER positive breast cancer with an average age of 60. In 80% of the women, cardiovascular disease risk was greater than the breast cancer risk, and in 37, but up the top here we've got in about 43% it was about equal, and about 20% the breast cancer risk was greater. So it doesn't necessarily increase. Now, if we look at recurrent breast cancer and menopause therapy, this is the LIBERATE study. And the LIBERATE study was a study of 3,000 women across the world, multi-centred. Monash, we at Monash Medical Centre were one of the sites, and it was a placebo-controlled study. 50% of the women were node positive and 50% of the women were node negative. There was no, the numbers on tamoxifen and aromatase inhibitors were not really sorted out very well. But at the end of the study, there was an increase in the risk of recurrence in those on tibolone. The original protocol said that there would be a 15% recurrence rate, and there was a 15% recurrence rate in the tibolone arm. There was a 10% recurrence rate in the placebo, but the hypothesis was of the study that there would be no difference in recurrence rates. And because there was a difference and the hazard ratio was 1.4, tibolone was therefore not considered to be safe to use in women with breast cancer. Interestingly, there was a very small number on aromatase inhibitors. And this is where the concern is that the suppression of estrogen is so low with aromatase inhibitors that maybe part of the increase, there was a trend in the AI group, but it's too small in number to be significant. But the trend could be that tibolone then was acting as an estrogen or estrogen and progestin, and so therefore could possibly increase that risk. Now, what about therapies? And Sonia alluded to it. There are a lot of non-hormonal products that we use for the treatment of just vasomotor symptoms. So when we look at non-hormonal therapies, we're just treating hot flushes and night sweats. We're not looking at any other menopause symptoms at all. So most of the studies are small, 3 months or less, and so there's no long-term safety and efficacy data at all. Some of the original studies on the SSRIs started in the 90s. And each of the studies, there's also methodological problems in being able to look at each individual study or different researchers and look at their studies and to be able to compare them. And there's limited head-to-head studies. And then, of course, when people stop their therapy, the symptoms in the main come back. So the other aspect is also the perception of response. And it's a very busy slide and it's very hard to see. The SSRIs had a very small, was a small improvement in 4 of 6 trials, clonidine 4 of 7 trials, and gabapentin 2 of 2. But the satisfaction threshold was really quite small, with a small number, with a lot of people were satisfied even with a small reduction. So if somebody has a 30 or 40% or 50% reduction, it's that much from what it was before. And for some women, that's enough to be able to say, I'm satisfied, even though they've still got 50% hot flushes and sweats still. But the reduction in 50% for many of them is enough to be satisfied. So what would be our first-line therapies? So 30 to 70% reduction, depending on the agent. And we've got a very busy slide here, but basically the first one is paroxetine, and there was a percentage reduction was up to 60%. The dosage, in America they have a 7.5 milligram tablet of paroxetine, which has been approved of for the management of menopausal flushes. We would tend to use about 20 milligrams here because that's the size of the tablet in Australia. Venlafaxine has had probably the Loprinzi is the man who started doing studies on venlafaxine in the 90s, and that gives about a 60% reduction in flushing and sweating. Escitalopram round about 50, gabapentin 60 to 70, and that's in a dosage that ranges between 900 and 2,400, the studies have shown. And pregabalin also 150 to 300 milligrams has about the same reduction as the gabapentin. So what's the choice? The choice is about what are the main symptoms that a woman has and how are they affecting her quality of life. So if somebody's mood and sleep are being continually affected, then maybe you look at combined therapies. So at Monash, we would use as a first line, we would normally use escitalopram rather than venlafaxine. It appears to have lesser side effects, lesser effects on sexual function, and meta-analysis has shown that it seems to be the most effective. It's a dose that we would start, we might even start with half a tablet, 5 milligrams, and build it up to 20. Gabapentin and venlafaxine have also, studies have shown that their effect is equivalent to a low dose of estrogen. And more we're considering looking at using both. So if we look here, we can see that in both studies that a combination of the gabapentin and an antidepressant has a more positive effect on symptom relief than isolated gabapentin on its own. Now, so we would start low and build up to the expected maximum effect to avoid side effects. Remember that these treatments start quickly. So if a woman is put onto one of these medications and at the end of 4 weeks, 4 to 6 weeks, she's been on the maximum dose and there's no relief, it's probably not going to work with her. So it occurs, the response occurs quickly. And there are some studies that show the response starts within 2 weeks of being commenced on these therapies. The limitations of the SSRIs is in breast cancer patients on tamoxifen. There is some data to show that the effects of tamoxifen are inhibited because of the competition with the enzyme here in the liver, and they both metabolize through the same process, and the effects are thought to be less. There is a small number of studies, one in particular showing an increase in mortality in those women who were on both. Many women will stop the medications because of side effects. That's mainly, particularly with gabapentin and pregabalin, that many women feel drowsy. It's good for sleeping, but they feel drowsy and they can't really function the next day as well, and quite severe dizziness. However, if they stay on it, most of those symptoms should resolve within about 4 weeks. But if they feel like that even for a short time, many of them will actually stop taking them. Now, clonidine I haven't mentioned clonidine, but clonidine doesn't have as much of a positive effect on flushing and sweating, and we tend to only use that if the others have not had any positive effect. Even though it's been around a long time, and many years ago when I first started working in the area, we used to use clonidine as a first line, and we used to have a 25 microgram tablet, and now we have only 100 is the lowest. But it doesn't appear to have as much an effect as the SSRIs or the SNRIs and gabapentin. Now, what about the across-the-counter products and other natural therapies and acupuncture and all of those things? So let's have a look. It's a very complicated slide. Amanda's into good complicated slides. I don't know, is it an endocrine thing? I think it's an endocrinologist thing. Basically, this is from NAMS, the North American Menopause Society. It's a position statement, and they looked at a whole series of products. We've got agents with inconsistent reports of benefits on vasomotor symptoms, genistein and diacetyl, equol, and then flaxseed, red clover, extracted and synthesized phytoestrogens, dietary soy, and vitamin E. Well, I think Sandra would agree and would recommend to us that a diet that's high in phytoestrogens doesn't appear to have any increase in risk in breast cancer recurrence in those patients. But those synthesized or extracted phytoestrogens, there's no safety and efficacy data on those. Some data possible with black cohosh, exercise, acupuncture, and then further study looking at hypnosis, cognitive behavioural therapy. And there are quite a few studies now on cognitive behavioural therapy, and Myra Hunter in the UK has written and published quite a lot on CBT, and the studies have shown about a 50% reduction in hot flushes, improvements in sleep, anxiety and quality of life. And the programs have been 4 2-hour sessions once a week, either individually or in a small group. Now let's go on to one of my pet subjects, and that is about vulvovaginal atrophy or genitourinary syndrome of the menopause. I just want you to remember that broadly about 60% of women have symptoms. It's only estimated, and the symptoms increase with age, and it is the one group of symptoms that don't disappear with the passage of time. In the WHI study, 2/3 of the women had evidence on examination of atrophy. Only 10% said they had symptoms, and only 7% were actually treated. And as I've said, it increases with increasing age. Now, genitourinary syndrome of the menopause is a new term designed to incorporate not only symptoms but also signs. And the symptoms not only they incorporate sexual symptoms such as arousal, orgasm and desire, not just the physical symptoms of atrophic changes. And it looks also at the signs, which will also look at urine infection, etc. So this is a good paper to actually have a look at and read and be up to date with the whole genitourinary syndrome of the menopause. So as I've mentioned, there are more severe symptoms. There are more urogenital symptoms in women after breast cancer, particularly those who go through menopause because of their treatment. Those women who go through menopause because of treatment plus risk reduction surgery. Chemotherapy can actually have negative effects on vulval and vaginal tissue, and as I've already mentioned, adjuvant therapy as well. And the important thing about it is that it impacts completely on quality of life. So the management will depend on what is the basic history, how old the woman is, the type of cancer, prognosis and response, her response, her well-being, her quality of life. And it depends on the severity of the symptoms and also whether she's just got vasomotor symptoms, whether she's got both the GSM and the vasomotor symptoms, and the impact that these symptoms are having on their quality of life and her ability to function. Depends on what this partner's like. How is she living in her lifestyle? How is it impacting, how are the symptoms impacting on her ability to function? In particular, her sexual function. And also about the attitudes of the health professionals who are looking after her. What is the attitude of the oncologist, the breast surgeon, or the GP, or the specialist who's the gynaecologist or endocrinologist who's looking after her? So we need to exclude other conditions, and then we need to look at what can we do? Well, we can look at lifestyle modification. We can look at vulval hygiene. So vulval hygiene, no soap, cotton undies, plain white toilet paper, wash their undies in ordinary pure soaps, those sorts of things. Use 100% cotton panty liners, or if they use them might use them for leakage, etc. And to stop smoking. And then we can look at moisturizers and lubricants. We can then look at vaginal estrogen, but it does depend on what the woman's been told. If she's been told never have estrogen ever again, which a lot of people have been told. But we know that estrogen is the most effective treatment. But there's no safety data in those with AI use. And we would prefer to use estriol rather than estradiol. And we also might consider asking that she be switched to tamoxifen. Now, this is a paper by Amanda de Vincent, who is the senior endocrinologist in the menopause unit at Monash. She's written this paper in Climacteric in 2015. I recommend to you also that this is a great paper to read. And she's given this algorithm on what to do for genitourinary syndrome. So lifestyle changes, regular sexual intercourse is a good way of keeping vaginal secretions going. Moisturizer such as Replens, exclude any dermatological reason, and lubricants. And look at estriol, as I've mentioned. And this is an algorithm for those women with sexual dysfunction. So looking at the genitourinary syndrome, referring to Geneta, vaginal dilators, changing medications, and psychosocial intervention with counselling, couple counselling, and education. I'll go very briefly through this very quickly, but there is a distinction between the moisturizer and the lubricant, and the importance is about osmolality and pH, so that you want it to be very similar to what the natural vaginal secretions are, and you want them to reduce pain and discomfort and reduce friction. But most of the products that are available actually have a much higher osmolality. And the problem with osmolality as it gets higher is that it can cause irritation, it can cause a contact dermatitis. And for example, in young people, not in these breast cancer patients, but in a young couple who are trying to get pregnant but need a lubricant, it actually can be cytotoxic on the sperm if the osmolality is too high. So we know that lubricants are used for improving and stopping vaginal dryness and lack of lubrication during penetrative sex. We have to be aware that water-based are non-staining, but they do have a lot of different products in it which will affect the osmolality and the pH. And the pH should be acidic rather than non-acidic. So it's appropriate to look at what they are, look at the ingredients on the packet. Now, moisturizers are different, like Replens. It rehydrates the mucosal tissue and it lasts about 2 to 3 days, and the substance mimics the vaginal secretions. Once again, it contains a whole series of other excipients. This is an interesting little study called the Overcome study, and it is the use of olive oil for lubrication, vaginal relaxation, a vaginal exercise, and a moisturizer. And it showed that there were improvements in sexual pain, sexual function, and in quality of life. So it's only a small study. Unfortunately, 6 of the cases had vaginal stenosis that they didn't actually note during screening. So important always to check the vaginal entrance when you're doing an examination and see how elastic it is, or whether it's narrowed, and whether it could be an issue in dyspareunia. Now, vaginal estrogen, a study showed that 3/4 of women would not use it because of the attitudes of their health professionals, and yet there is no good, strong evidence to either support or reject the use of vaginal estrogens, even in women on aromatase inhibitors. The reason for the concern is that plasma estradiol levels can be dropped really low, down to 3 millimoles per litre. So we know that there's increasing use, and we know that vaginal dryness and dyspareunia are really common symptoms, and yet they can be made worse by the aromatase inhibitors. Now, vaginal estriol, we have 2 products available in Australia. We have Ovestin cream and ovules. And we know that it has a lower estrogenic potency than estradiol. We know that it's the major estrogen of the placenta, and it has a greater affinity for estrogen receptor beta than alpha. So it minimises the extravaginal effects. And the most important thing is that estriol cannot be transformed or metabolised to estriol or estrone, whereas estradiol can be. If we look at some study on absorption, this is a study from 1980. So we've got E1, E2 and E3. So we've got the estriol, we've got estrone and estradiol. And if you look at the, this is in hours, this is day 1 and this is day 21. And you can see that even after 21 days, there really is no significant difference in estradiol levels with the use of estriol vaginal cream. You get the peak of absorption after the introduction of the cream, and then that lowers down by the end of 6 hours. So I'm under the pump here. So you can see that the estriol level goes up as it should, but the estradiol level is the same. Now, Vagifem low is only 10 micrograms. The annual estradiol exposure is only 1.1 milligram over 12 months. So even that is extremely low. So you get minimal systemic estradiol absorption as well. And there's no evidence that there's any endometrial hyperplasia, but it does improve the symptoms. Now, if we look at the absorption here, this is from Richard Stanton. This is over 24 hours, and it gives you 1, 2, 3, 4, 5, different days, so up to day 83. And this is day 1. So you see there's a peak at about 8 hours. But then if you look at day 14, it's very flat. And then you see here at day 82, the estradiol level is even lower. So once the vagina becomes estrogenized, there's no peak absorption of estradiol after that. So we have to look at those issues and what the effects might be. We can see that the absorption is relatively low in those particular products. This is a study looking at a very low dose of estriol combined with a lactobacillus. And this showed once again a very low dose and very effective and improved vasomotor symptoms in patients on aromatase inhibitors. Just very quickly, 2 products that are not available here but are available overseas. One is ospemifene, which is an oral non-steroidal estrogen receptor agonist antagonist. And it has full estrogenic effect on the vaginal epithelium, and it improves vaginal dryness. Excuse me. It has a low rate, about 13% of hot flushes, but not been studied in breast cancer survivors. And the other is a gel or treatment with DHEA, and that has also shown efficacy in reducing vasomotor symptoms. Laser is something that's been around now for a little while. There are no long-term studies, but there are departments around the world and practitioners using vaginal laser for the treatment of vaginal dryness and vulvovaginal atrophy. We really need to have much more long-term studies to show that it's effective. The cost at the moment varies, but it is quite expensive. It's usually given 3 doses over 12 weeks, and that is often repeated once or twice a year. But I think at the moment we don't have long-term data. And lastly, I just want to talk about BRCA positive women. We know that it reduces the incidence of primary ovarian cancer by about 95%. So, and it's important for the surgeon to take the whole of the tube. It also reduces in BRCA2 positive mutations about 70% and one about 35% in terms of breast cancer risk. And they're in those women who haven't had mastectomies. So, and the age for doing a risk reduction is somewhere between 35 to 40, preferably after the woman has had her family. And it's often associated with prophylactic bilateral mastectomy, and that will reduce the breast cancer incidence by about 90% in those BRCA positive women. So there's a practice pearl from NAMS, which says that limited data that the risks of breast cancer are not increased by hormone therapy, with the use of hormone therapy by BRCA mutation carriers with breasts. Young women with or without should not be deferred from having the risk reduction surgery because of the subsequent use of systemic therapy. So a lot of people don't go and have their ovaries out because they're concerned about the long-term risks of HRT, yet they're young women and they should go ahead and have that risk reduction surgery because of the, the reduction in the incidence of primary ovarian cancer in doing that. So just a last couple of slides. This is a recommendation from the College of O&G in, forgotten which year now, 2016. So non-hormonal approaches for the first line for vasomotor symptoms and urogenital symptoms, estrogen, vaginal estrogen, women's oncologists should be involved, and an informed decision-making and consent process. So there's no data that says that an increased risk of cancer recurrence amongst those women who've been using vaginal estrogen. We just don't have the data, and it's more theoretical. And this is a slide which looks at the different options for GSM in breast cancer survivors, and it's basically the main thing. But non-pharmacological intervention, laser, counselling, psychosocial distress management, regular sexual activity, and we need larger trials, but using vaginal trainers, pelvic floor therapy, and local anaesthetic, which Janetta often recommends to patients. Thank you very much.